Okay, I'm Jas Gill. I'm a emergency medicine physician that trained in both trauma surgery, and I now work in the CT ICU. So I'm an intensivist. I actually do a 100% ICU care at this point, but the majority of my training is in trauma critical care. I do a lot of pigtails almost on a weekly basis, actually on a weekly basis. And then surgical drains we do on our traumas. Okay, so chest tubes. So essentially this is your patient that's come in with a pneumo or a hemothorax and you have to evacuate the pleura. You always want to gown up sterilely. If your patient is laying supine like he is, you want to make sure that the arm is up. Depending on how fast you're going to do this, it can get really uncomfortable for a patient to hold their arm up themselves. So you may want to tape it down or put a tie around their arm or something like that. So you gown up, gloves, full sterile precautions. You clean the area with betadine, chloroprep. If this is a crash drain that you need to get in there immediately, just grab some betadine, throw it on there, go crazy. So once you've cleaned, you want to drape. If you have some time, you want to drape. And then you want to take some lidocaine and just numb up as much of the area as you can. The kits typically come with like a 5 cc vial. I always grab at least one more, so I have 10 cc's. I give a little skin wheel because there are 3 major areas that hurt on chest tube insertion, right? So anyone want to throw them out? Skin, perfect. Periosteal, yes, exactly. And the pleura, yeah, exactly. Those are the big 3, right? The sub-Q is very well tolerated. If you have a super muscular person, going through muscle can be A, difficult, B, painful. So just be mindful of that as well. So yeah, so I start off by giving myself a little subcutaneous injection, kind of massage that in. Then I take my needle, go all the way down to the pleura. And you feel the pleura because it's a tougher membrane and you can kind of like feel a little give. I pop through the pleura on the other side and then inject on the way out. That way you kind of injected lidocaine into the pleura, around the pleura, and then that's my first round. And then with the second 5 cc's, I actually go to the rib and numb up the periosteal space. So then why do we go above the rib? Because, yeah, the neurovascular bundle runs below the ribs, right? Excellent. Okay, so you've numbed up your patient, and while the lidocaine is taking effect, that's when I set up my drains. This is how kind of like the standard approach, right? So one of your colleagues was actually telling me, we don't have this little plasticky bit up here, the hard plastic, that you guys have apparently. So she said, so what I do is I just clamp here at the very tip, but apparently these things can break, so don't do that. Yeah. Sure, it may just be this particular drain. So if you have something that looks like this, don't clamp at the end, okay? But you can just go through the fenestration and clamp here. The only thing that matters is you grab a curved Kelly and that you clamp it in a way that maintains the curve of your wrist, right? So you clamp it like this. So once you've done that, and this is like a standard 24 French drain, there's only 2 fenestrations on this for whatever reason. Normally there are a few more fenestrations. These are the radiopaque markers as well as the line on the side, so you can see if your tube's migrated out on subsequent x-rays. Okay, so you've set this up. You can or can choose not to have a clamp on the other side. If you're expecting a massively bloody hemothorax and you want to be nice to people who have to come and clean after you, put this on. If you don't have the time, this is doing nothing. Okay, so then you're ready, your lidocaine's kind of taken effect. Aside from these 2 clamps, you always want to have like the smallest clamp available because it's small, so you can manipulate it more, but it's also the finest tip, so you can actually pop through the pleura more easily. So you pretend that there isn't already a cut on the skin. You make yourself a good cut. Don't give yourself a teeny tiny cut. This is not cosmetic surgery, right? You're doing it for a reason. So give yourself a good wide cut. So at least 5 centimeters, if not longer. And then once that's through, this is really, the rubber is really tough, so I've already hurt myself once. So you find you're now under the skin, right? So you feel for the rib space again. Make sure you've identified your landmark. You put your finger. So if this is the rib, don't lose a harpoon. Yeah, okay, that's fine. Thank you. So if this is your rib space and you're going above, I position my finger here, and that's my guide for where I need to pop in with my Kelly. Okay, thank you. So now you've popped in with your Kelly, and you'll feel the pop of the pleura, right? Once you're there, you can take your finger out, and then open up your clamp to really open up that pleura. Before I take my Kelly out, I replace it with my rubber. Okay, I replace it with my finger. Less of a problem in your population because you guys are nice and skinny. More of a problem in my population because we're not. So you don't want to lose the track that you've made, right? As soon as this comes out or your finger comes out, the subcutaneous tissue collapses. And you don't want to keep doing the same thing over and over again. So you leave your finger in the space. Now you take your preloaded drain, and then again, oh sorry, one thing I forgot to mention. Once your finger is in, you want to sort of move your finger around. You want to feel that the lung has re-expanded and you can actually like touch it. It's in your field. You want to feel for any adhesions that may be present. Maybe this guy had a prior chest drain, right? You want to take those adhesions down with your finger, and they tend to be pretty pliable, so it's very possible. And then if this is like a retained hemothorax that's been sitting there for a few hours, few days, you can form blood clots, right? So you want to kind of push those out of the way because they can very easily clog up your fenestrations, and then your chest drain becomes less effective. Okay, so you push this in, you can cheat. And then it's really actually hard to push the drain all the way in on him because he's rubber, but you want to push it past the markers. Once that's done, you're done. You take this off. You attach this to the Pleurovac. Everyone familiar with how to set up a Pleurovac? I don't need to go over that. I see some questions. Okay. Very simple, very dumb machine. So this will kind of come, these are always the same because it's the same company. This will always come kind of coiled in the back. You want to find your syringe. Oh my gosh. You want to find your syringe of saline. You want to find this opening. Push all your saline in. There's a little chamber at the bottom, which it did not open up, but oh well. You want to push all of that in, and there's a little layer there that comes up, and that's your fluid level, right? That's what creates your one-way valve, so you're not sucking air the other way around. Okay. Once that's done, this is the part that goes to your drain, and then this tubing is what attaches to your wall and goes back into this place, okay? And this may be slightly different. I may have had to put it in here, but it doesn't matter. Other things on the drain itself that you should be familiar with and be able to manipulate are the suction thing, which looks a little bit different on some different drains, but sometimes you've done all the right steps, but your wall suction is not working, or the wall suction is too weak. So you want to make sure that this plasticky diaphragm actually raises up. That tells you that you're on suction. And sometimes when you're transporting your patient, right, they come off suction. When you put them on water seal, they come off suction, and then somebody forgets to plug them back in. Now you have a reaccumulated pneumo. So when this is on suction, the diaphragm rises up. It can look a little different on some different pleurovacs. And then you can always change how much negative pressure you're applying to the cavity by manipulating this dial. But that's it. Nothing more to it. Let me see if I have some suture. So how do we secure a drain? A lot of people are taught in different ways, right? So if this is your drain, no, that's a wire. So if this is your drain and this is your skin, it's going through, you want to take a bite on this side. So come out on the same side, just take a skin bite, and then tie an air knot, right? So an air knot is over here. An air knot is essentially a loop that you don't cinch to the skin, right? There's a little gap between the knot and the skin, because you've all done central lines or other kinds of drains where the patient is really uncomfortable, right? And then you go look at the skin and the knot's pulling on the skin. That's the most uncomfortable part. So you never actually cinch it down to the skin. That's very painful, and it's constantly pulling on your skin. So tie an air knot, and if you don't know how to tie that, we can go over it very quickly, but I may not have enough time. But essentially, you've gone through the skin, you've come out, now you're tying, but if this is your skin, you want to tie on my finger. So there's a gap of this much between your knot and the skin.
Do you use anything as
you can
to put it like in between, like
yeah, exactly. You can. I do this frequently enough that I have a feel for it. But if you don't, take your Kelly, stick it in there, and tie on the Kelly. When you take it out, there'll be a nice little loop there. Okay. So once you have an air knot, you now have two long tails. You go around the drain a couple of times, and then you tie on the drain. So this way, there's no knot on the patient's skin. Yeah. And the drain is secured to your air knot, so it's not going anywhere. Yeah. Make sense? Okay, so it's much more comfortable that way. And then you put like an oil emulsion dressing at the site, so Zeroform or Vaseline gauze or something that's not that's water repellent. So if they have some air leaking out, if they have some blood leaking out, it's not gonna maintain your barrier. You kind of wrap that around here. Then I put some gauze, and then you can put silk tape or the stretchy tape that you have. And then the one thing I do is I make a mesentery. Everyone know what that is? Okay, that's fine. Someone else said that it was like the little stat lock. You can do it on the smaller drains, but you're not going to be able to fit one of those on here. So you just take a piece of silk tape, you wrap it around your drain, and you cinch it here, and then you attach that to the patient. Does that make sense? Okay, so it's not like you're slapping some tape on here. It's a wrap around the drain, put that to the patient, and that takes the tension off, like say this gets pulled or whatever, right? That takes the tension off the end of this. Okay? And you get a chest x-ray, and your patient's very happy. So everyone's familiar with our basic Seldinger technique for things? Yes. So basic Seldinger technique, right? You've, now this may be, again, a traumatic hemothorax, a pneumothorax, or you may just be doing a pleural drain for a pleural effusion that's accumulated over time, right? So depending on where the effusion is, if it's loculated, if it's free-floating, if it's simple, complex, blah, 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 you can position your patient in different ways for that. The two common ones are supine like this, and I put a little buffer on the other side, like a pillow or something that topples them. And that way the effusion is in the most dependent area and you have a bigger effusion. Or you can have them up at like a 30-degree angle, and that way again it will layer posteriorly. If your patient's awake, if they're talking to you, you can have them sitting upright and leaning over a table, and the leaning kind of opens up the ribs in the back. I always take, I don't do this dynamically under ultrasound, but I always take an ultrasound probe and make sure that I'm above the diaphragm. I've seen drains that ended up in the liver or in the spleen, and you never want to do that, especially on an ECMO patient, which is what happened. But anyway, that's neither here nor there. So you've identified your pocket, you've identified that this patient needs a drain, and so you do the same steps. You gown up, full sterile precautions, you've cleaned the area, you can put your ultrasound away because you know where you're going, or you can like put a little marker on the skin for where you think your needle's gonna go. You've taken some lidocaine, you've numbed your patient, and while the numbing, same thing, right? While the numbing is taking effect, you set up your kit. The kits will all have the same basic steps like you do in any central line, but depending on the size of your drain, you may have an extra step. So this is, anyone can visibly tell me how big this drain is without cheating? Does this look like a central line size? Yeah, like a triple lumen, right? This is about a triple lumen thickness. Okay, a standard triple lumen is about 8 French. So this is the same thickness as a triple lumen or a double lumen central line. For this one, you don't need that extra step because it's very flimsy and pliable. For the thicker drains, the 14 French pleural drains, there's an extra step. If you try to put the pigtail on those through the skin, it doesn't go through because it just doesn't straighten out, and you can kind of curve it in the sub-Q. So for those, they come like this, right? But there'll be a stylet that you have to introduce on the other side to straighten the drain out. But that's just that will be very obvious if that's in your kit, okay? If you don't, then you have this regular guy. Okay, so same basic concept, right? I always hold at the most proximal site, so I have control. As soon as you go through skin, you start to pull back, and you hopefully get a rush of air, or you get a rush of fluid. With your non-dominant hand, because I'm a righty, I secure. If you have the ability, whether you're doing ultrasound, whether you're doing procedures, always have something to stabilize against the patient, right? So I secure the needle, and that way it's not going anywhere, right? Take this off. Find your wire. Now this typically comes loaded in some way, like this, right, in a coil. And then you have the straightener piece, which is right here. Anyone actually know what this is called? I have no idea. I've never been able to figure this out. But just a quick little note, and this applies to any time that you have to use a Seldinger technique, A-lines, central lines, pigtails, whatever you're doing. It always comes like this, right? In the kit, it's a J-loop. So you push this, but some people will push it all the way, and then they have a hard time engaging the needle. So you want to have just a little bit of the tip sticking out, and that's going to be straight enough, but you can engage the entry point on the inside of the needle. Sometimes it gets really frustrating because you're like trying to pass the wire and it's not passing. It's because the tip's not engaging, okay? The other thing is if you have a kit, say, that doesn't have this handy dandy piece, these are all elastic coil wires. Every J-loop will be the standard. This should be a 19 millimeter. Because they're elastic coil, if you push them, it straightens the loop. It's a little bent, so it's not perfect. But if you push against them, if you pinch and push, do you see how it straightens the tip? In a perfect world where the wire is not already bent, it will fully straighten the wire.
If you pinch.
Yeah. If you pinch and push. Okay? So if you want to practice, go for it. But so we'll do this. So you take your wire. Come on. You have a little bit more hand-eye coordination than me, and you push the wire in. Most of the time your patient's awake when you're doing this, right? If you've ever done this before, when they feel the wire in their pleura, they cough. It's uncomfortable, and a lot of the times they will, say something like, "Oh my gosh, something's wrong," right? Because they feel the discomfort. So just reassure them that everything's fine. This is just how it feels. Okay. So now this being the Seldinger technique, right? Everything is on a railroad. So this is your railroad, right? You will always have plenty of wire in a patient like this. So you're not too worried about it migrating in, but still be mindful of like how much is out. And then everything from this point on depends on the integrity of your wire, right? So you load the dilator on, and then same thing as any other Seldinger technique, right? Corkscrew in, corkscrew out, corkscrew in, corkscrew out. When you're coming out, you're physically ripping the fascial planes on your way out. So you'll notice when you pull out, there's a little skin tent that comes with you, right? That's perfect. That's what you want. You want to tear that fascia. And then the more you go in and out, the smoother it becomes, right? You want to introduce it to a point where you feel the pop of the pleura, and you always will feel the pop of the pleura. And once you do, it'll become smoother on your way out, okay? And then sometimes in really muscular people, this can be forceful, right? But never push something procedurally. Central line, A line, chest tube, drain, whatever you're doing. If you are having to like put your back into this procedure, you're doing something wrong and you're hurting your patient. So you either need a bigger nick, you need to dilate more. And the reason that's really important is, right, remember I said everything is about the integrity of your line. So if you push really hard, these dilators are pretty pliable also, right? So it bends in your skin and it bends the wire. Once your wire is bent, you've already lost. You kind of have to start over. Okay, so you've dilated enough, you come out, and then because this is just flimsy enough, it just feeds right onto the end, just like a central line. And then you'll notice there are a couple of markings on the side, and then a couple of really tiny fenestrations on the distal tip. You definitely want to make sure that all the fenestrations are into the pleura, but you don't always have to hub your pigtail. Depending on how far in you had to go with your dilator is kind of what mark you need to go to. Always give yourself some wiggle room though, so like say you only needed this much of a dilator because your patient's super skinny, still push the drain in a little bit more, right? Because it's super flimsy and it can fall out. Okay, so now you've pushed it in, you've taken your wire out, the pigtail is now on the inside of the pleura. This comes separately. Always make sure that your stopcock is on off when you insert it. That way, say you're doing this and the patient takes a really deep breath, coughs, does whatever. If it's not to stop, it's going to suck air right in from the environment, right? So you can make your tension pneumo or your pneumo worse. Then you've got this little handy dandy thing on the other side, and then this piece goes to the end of the drain, the pleura back, I mean. And then you can take off samples. You can attach this to a bag like this, let it drain by gravity. Or you can take a 60 cc syringe and just draw an effusion out if you're doing it for like diagnostic reasons. Okay, and then I secure my drain in the same way as a chest tube, so air knot on the side and then wrap it around the drain, tie it on the drain. These, just be mindful that you don't really tie it too tight, otherwise the drain's gonna compromise. Okay, and for these you just need to slap on a Tegaderm and you're done. Okay, sorry for running over, but cool. Hope that was helpful.
Thank you.
Yeah, anytime. Oh gosh, please don't.